Very good evening to all of you, ladies and gentlemen. It's a proud privilege for me to welcome you to the 10th webinar of the series on this capsule on sleep medicine. And I'd like to thank the Indian Chess Society for giving me this opportunity to be moderating this last session. And it's been a wonderful journey all over. And I think there have been more than record number of 2,500 logins for each and every webinar, and it has been super successful. Thanks to the team of Dr. Rajadhar, Dr. Samaria, and Dr. Amita Nene. And also kudos to Cipla Respiratory for being the academic partner of this entire module. So this is going to be the last webinar of the series, which will be followed by 5 workshops, which will be spread all over the country, which you will be coming to know at the end of the webinar. And we have got a very star-studded faculty today from the pulmonology lexicon of the country. And we have got some very prominent and eminent sleep medicine specialists as speaker and as well as the faculty for the panel discussion, which would follow the talk. So the speaker for today is Dr. J C Suri. Suri sir needs no introduction, and he's been the pioneer of sleep medicine in the country. He has been the former professor and head of department of Safdarjung Hospital, where he had set up the DM course as well. And he needs no introduction but for the younger faculty, he has got training abroad in critical care at Loyola University Medical Center, Chicago, as a WHO fellow, and he's also received sleep medicine training at Stanford University, Palo Alto at USA again. And he has got significant, milestones in sleep medicine in the country, and he had started the first clinical sleep laboratory as well as a physician-run ICU in North India, and has got extensive experience and leadership. He's got international training, and he has been the founder of JCS Lung and Sleep Center since 2020, and which is providing comprehensive care for respiratory and sleep disorders to all those who are in North India. And he's been an academician and a pioneer in medical education and research, and has contributed more than 100 research articles, and has got special interest in sleep medicine, and has also contributed to development of national healthcare programs in the country. So he's got numerous, credits and awards to his credit, and throughout his career, he's got numerous awards and orations, including the Vishisht Chikitsa Ratan Award by the Delhi Medical Association. So without much ado, and I won't come between you and the speaker, I would now request Dr. J C Suri sir to kindly speak on PAP therapies, which is the main topic today from A to Z. Over to you, sir.
Can you see my slides? Okay. So at the outset, I would like to thank Indian Chess Society and particularly Dr. Nene for this kind invitation. And I would also like to thank Dr. Marwah for a nice introduction. The topic which has been given to me is a very important topic. It is very practical topic, and at the same time a bit confusing to majority of the chest physicians. So I'll be talking about PAP devices from A to Z. So when we talk about PAP devices, then what we mean is different devices. So when you should have different devices, when there are different issues there, because each device is going to address a particular problem. So whenever you think of prescribing a PAP device or a particular mode, it is important to know the pathophysiology of sleep disorder breathing being treated, because sleep disorder breathing is a heterogeneous group of disorders. Each has its own etiopathogenesis. To address those etiopathogenic factors, you need different types of modes and devices for this thing. And broadly, we can divide sleep disorder breathing into two categories. One is one which is related with abnormal rhythm, as you can see. So in this, you have two categories: obstructive sleep apnea, where you have upper airway obstruction, and the patient with unstable breathing, also known as central sleep apnea, which you particularly see in patients with congestive heart failure, drugs like opioids. And then you have a group of hypoventilation syndromes, where the patient has primarily sleep-linked hypoventilation. And this is due to loss of accessory muscle contribution to ventilation during sleep, particularly during REM sleep. And this kind of sleep-linked hypoventilation we see in patients with chronic disorders like obesity, COPD, neuromuscular disorder, obesity hypoventilation syndrome. So these are the common conditions which we see. And of course, the last situation where you see only ventilation perfusion mismatch, which usually presents with hypoxemia, and it may or may not be associated with hypercapnia or hypoventilation. So when this is purely hypoxemia, then we don't need to use any PAP device except oxygen in these cases. So when we are now talking about, uh, just let me see, it's obstructing my titles. So just a minute. Yes. So what are the devices which are being used for treatment of obstructive sleep apnea? In this, we have CPAP, bilevel CPAP, CPAP with C-flex and A-flex, and then auto CPAP. So what we basically address, what kind of pathophysiology we address in this is the upper airway obstruction, and the mode of action is what you called as pneumatic splinting of upper airway. Basically, when you give CPAP, you actually increase lung volume, and with this increase in functional residual capacity, there is also increase in the upper airway size. It also changes the tonicity of the upper airway. It makes it much more firmer to prevent its collapse during sleep. There is no augmentation of ventilation with these devices. The second group, which we mentioned, is the devices and the modes used for central sleep apnea and Cheyne-Stokes breathing. In this also, we use CPAP particularly for patients with high loop gain and patients with congestive heart failure. And then we also use bilevel device. This bilevel is different from the bilevel which you use for obstructive sleep apnea. This is called bilevel CPAP, and this is a bilevel ST, which the one which has a backup rate. And then there is a special device which has been designed and developed to address periodic breathing or Cheyne-Stokes breathing, which is associated with congestive heart failure. So it basically modulates respiratory pattern. We call it adaptive servoventilation. Here, this device is also associated with reduction in the minute ventilation. So unlike other devices which enhance minute ventilation, this device reduces minute ventilation because most of these disorders are associated with hyperventilation and they are hypocapnic by and large. And the last group is the one which addresses sleep-linked hypoventilation, and this kind of bilevel devices we call bilevel ventilatory support. So you have bilevel CPAP for OSA and bilevel ventilatory support to address sleep-linked hypoventilation, and this may be available in different modes like spontaneous mode, spontaneous time, and bilevel ventilatory support time, which provides only the control mode where there is no spontaneous breathing. It's totally a controlled breathing like you have in invasive ventilation where the patient is sedated and paralyzed. There's another mode which is called volume assured pressure support VAPS. So this is available in two different models from ResMed and Philips as AVAPS and IVAPS. So we'll be talking about it in greater detail. So first, let's talk about so this is for breath augmentation. So let's talk about um, the devices used for treatment of obstructive sleep apnea. So that suppose if you have a patient of obstructive sleep apnea, then what type of device you will use? The most common device is CPAP, and then there are situations where CPAP is not going to work very well. You will choose either CPAP with C-flex or A-flex, bilevel CPAP, or auto CPAP. So that is what is very important for you to understand. So I'll elaborate a little bit more on this. So CPAP is definitely the first treatment of choice for all freshly diagnosed cases of moderate to severe obstructive sleep apnea. And why we should use CPAP for this situation because CPAP is the most efficacious treatment as it causes nearly complete resolution of abnormal obstructive breathing event, which we can confirm during a sleep study. And also it is the most extensively studied modality, and we have the largest body of scientific evidence in the form of systematic reviews or metabolic and meta-analysis for the efficacy of this treatment. Now, how does CPAP works? CPAP actually works on the principle of what we call as equation of motion. So what is this equation of motion? Is flow is equal to pressure gradient over resistance, or pressure is equal to flow into resistance. So what is a CPAP machine or a PAP device? PAP device is a flow generator. So how a flow generator produces pressure? So you provide resistance, and this resistance comes from the mask. And on the mask there are exit pores. You see multiple fenestras, and these fenestras, on the oral or the nasal mask provide the resistance. So the resistance basically depends on the type of mask, whether it is nasal or oronasal mask, and size and area of fenestration. So flow and resistance results into a development of pressure. So more the flow, more the pressure, because the resistance is constant. Once you use a particular type of mask, the resistance is constant. So more the flow, more the pressure. So that's how this is on the basis of this principle. And the air comes out, this flow comes out through these exit pores, these fenestra, and this leak is called essential leak or intentional leak. Because this leak, if this leak is not there, there won't be any pressure. So you need flow. This flow exits from these fenestras on the mask, and then that provides the resistance, and this results into pressure, and that pressure is transmitted into the upper airway tract. So this is very important for you to understand, because in the panel discussion later on, you will be talking about leaks, different types of leaks. So leak is an integral part of this system, and the leak which is required to produce a pressure is called essential leak or the intentional leak, which has to be there. So it not only generates pressure but also flushes out the carbon dioxide of the expired air. So this is how. So you see, as the pressure increases, the leak increases, and this leak, for a given pressure, there will be a given flow or the leak, and that will depend on the type of the mask, because different types of the mask will have different levels of resistance. So whether it is nasal, oronasal, or the nasal masks of different companies, different manufacturers, they will have different levels of resistance or fenestra. So you will have different. So you must know the level of normal leak or the intentional leak for a given pressure. And that's what you see. Normally, it is usually less than 24 liters for all pressures. It is less than 24 liters for a nasal mask and less than 36 liters for a oronasal mask. So this is one concept you have to understand. So this is how CPAP works, but there are limitations to this CPAP therapy. So CPAP is not tolerated by all patients. So CPAP treatment is associated with suboptimal adherence in large percentage of the patient, and the most common reason is intolerance of high pressure or difficulty in exhalation. Because normally when we breathe, you breathe out to zero pressure, but here you breathe out to that CPAP pressure. So people feel a problem in exhalation. The problem is not during inspiration, but the problem is more during exhalation. So this is another problem which you face with CPAP. Nasal CPAP is nasal stuffiness, and if there is coexistent central apneas or hypoventilation, then CPAP may not be a good device. So to address these problems, as you can see here, a number of modes have been developed, and the first mode which was developed was bi-level CPAP. So bi-level CPAP was actually developed to treat sleep apnea, not for ventilation. So this point should be very clear to you. So this device was first developed for patients who were intolerant to high pressure or face difficulty in exhalation. We know that to stabilize upper airway, you need more pressure during inspiration and less pressure during expiration. So that led to two pressures, one pressure for inspiration and one pressure for expiration. So you use two CPAPs to stabilize upper airways, to stabilize upper airway, and that led to development of what is called bi-level CPAP. So here, this device is not used for ventilatory support. It is not going to enhance the ventilation, but it is basically two pressures used to stabilize upper airway during inspiration and expiration, and they are different pressure. And this device was particularly used for patient who had difficulty in exhaling against high pressure, and this was seen in patients who require a CPAP pressure of more than 15 centimeters to treat obstructive sleep apnea. Then the next device which was developed was APAP. Now you may be surprised that most of the people now are using these APAP devices for the treatment of sleep apnea, but it was not developed for the treatment of sleep apnea. It was actually for titration, because when you take a patient in the lab, you do in lab titration and calculate or determine the pressure, fixed pressure for fixed CPAP. But when you do home sleep apnea testing, in home sleep apnea testing, you cannot do the in lab titration. So if you do a sleep test out of the lab, then the titration also has to be done out of the lab. And to do that titration, to find out or determine a pressure for fixed CPAP, this APAP was designed. It has different names: auto titration, automated, auto adjust, automatic CPAP. So there are different names for this thing. And this device was originally developed for auto titration of patient after home sleep study. The idea was to determine pressure for fixed CPAP. So that is what is there. It actually utilize a proprietary algorithm to detect and respond to changes in the upper airway flow or resistance in real time. So this delivers a continuous pressure which varies over time. Over time means during the night, there will be different pressure delivered, CPAP pressure, to keep the upper airway open, whether it is supine or it is in the lateral position, whether it is in the non-REM sleep or it is in the REM sleep. So that's how. And this the algorithms actually address to either snoring or to abnormal events like apneas and hypopneas, or in inspiratory flow limitation. So these are the different. So different manufacturers have different uh, proprietary algorithms which respond to one of these inspiratory abnormal respiratory events, and then deliver a pressure to keep the upper airway open in these cases. So this is how you can see the pressure varies across the night depending upon the level of upper airway obstruction, and also whether the patient is supine or lateral or in REM or non-REM sleep for this thing. So how you use this auto CPAP device? Once you have done the home sleep apnea testing and you find the patient has moderate to severe disease, yes, then you give them a PAP device for home use for 7 to 14 days. And then after this 7 to 14 days, the patient is given this device between 4 to 20 centimeters, and then the data is downloaded from the machine at the end of the trial. And then you calculate, the 90th or the 95th percentile pressure. That means the pressure at which 90% of the abnormal events resolved, or the 95% of the abnormal event absorbed. So that's how you calculate. And then you give this pressure to the fixed CPAP. So you are not going to treat this patient with auto CPAP, but you are calculating, determining a pressure to be given on the fixed CPAP here for this thing. So these are the various studies which are done to see whether you do in-lab titration and find a pressure for fixed CPAP, or you do the auto CPAP titration out of the lab. And what they found, that there was no significant difference in the residual disease in terms of compliance. So both method appeared to be quite similar. So that's how the auto CPAP was used for finding or for determining the fixed CPAP pressure. But then later on, the auto CPAP also being used for treatment of sleep apnea. So when you would like to use this auto CPAP for treatment of sleep apnea, It is basically for patients who complain of inability to tolerate degree of fixed CPAP pressure to prevent the respiratory events. So if suppose the pressure is 15 centimeter during REM sleep and say 11 centimeter during non-REM sleep, so and REM sleep is only 25% of the sleep. In a fixed CPAP, you will have to give 15 centimeter throughout the night. So in a situation where the patient cannot tolerate 15 centimeter, in such a situation, you may consider giving them auto CPAP. So patient who are subjected to factors that might significantly vary their pressure requirement, such as use of alcohol, nasal congestion, wide variation in body weight, REM predominant sleep apnea, supine position dependent sleep apnea. So in these situations, when the pressure requirement is higher, so these kinds of machine can be used. Of course, you will never use auto CPAP in treatment of sleep apnea with congestive heart failure, patient with lung disease, that means overlap syndromes, and patients with who are associated with hypoventilation, and those who do not snore, because most of the auto CPAP algorithm work on snoring, particularly sleep apnea patients who have undergone uvulopalatopharyngoplasty. So their snoring disappears. So in such patients, the auto CPAP does not work, for this thing. The another thing which you can use, to treat the difficulty during exhalation is giving expiratory relief, in CPAP. So when you give a 10 centimeter pressure CPAP to a patient, during inspiration, when the patient creates negative pressure, this 10 centimeter may become 8 centimeter. And during expiration, patient may develop plus 2 centimeter pressure. So this 10 will become 12. So this is how the patient finds it difficult. So there's another way is what is called flexing. Flexing means where you decrease the pressure during the initial part of expiration, and later part the pressure is restored so that the upper airway patency is maintained. So this is what is called A flexing and C flexing. So A flexing is when you use the pressure modulation both during inspiration and expiration, which is seen only in auto CPAP, or what you see in C flex. C flex is only expiratory pressure relief. A flex is both inspiratory and expiratory pressure modulation. So these are the another ways, So you have three types of expiratory relief maneuver. One is using bilevel CPAP. Second, you can use auto CPAP. And third, you can use C flex or A flex. So this is how, I hope now you understand what are the three different types of modes and devices which are used for the treatment of obstructive sleep apnea. Next, we go to the devices which are used for the treatment of central sleep apnea. Now, central sleep apnea is a rhythm disorder where there is a failure of rhythm generation at the central respiratory center at the brainstem level. So there is a failure. So these patients may do what happens. They have intermittent hyperventilation. So when they have intermittent hyperventilation in sleep, they develop hypocapnia, and this hypocapnia goes below the apneic threshold and they stop breathing. So this to treat this, we again have three types of devices. One CPAP, another one bilevel with ST. It's very important because when the patient has apnea, the machine gives breath according to the backup rate through ST, and the third is the adaptive servo ventilation. Now, why should CPAP be used in a patient of central sleep apnea when it is associated with failure of rhythmogenesis, the failure of uh, uh, the signaling from the respiratory center? So what happens that in most of the central sleep apnea patient, what happens that there is no respiratory drive. The upper airway muscles become hypotonic. The pharyngeal dilator muscles become hypotonic and they collapse. So in vulnerable patients with central sleep apnea, there is also upper airway obstruction. So to prevent this upper airway obstruction, we give them CPAP. So this is very important because when there is an upper airway obstruction and patient breathes, so there is a this and the upper airway is closed and patient tries to breathe, after the central apnea terminates, the patient has to generate a very high negative pressure. And this high negative pressure can trigger hyperventilation, ventilatory overshoot, hypocapnia, and additional central apnea. So that's why you use the sleep the CPAP in these patients. The another reason we use CPAP, particularly for patients with congestive heart failure, because it decreases preload, decreases afterload, it recruits the lung, decreases improves lung compliance, improves ventilation perfusion matching, improve oxygenation. So decrease ventilatory drive, decrease minute ventilation. So with the result, there is decreased hyperventilation. So all these things, so it stabilizes breathing. So CPAP has been found to be useful in treating central sleep apnea or periodic breathing in patients with congestive heart failure. But not all patients of congestive heart failure will respond to CPAP. It's only mild to moderate congestive heart failure with an ejection fraction of probably 30 to 40%. And more severe patients actually may develop worsening of congestive heart failure with CPAP, because these patients may be preload dependent. So that's why it's very important that we should choose our patient select carefully when we give CPAP. And CPAP has been found to decrease central apnea, improves nocturnal PCO2, decreases sympathetic activity, and also improves ejection fraction. So this Canadian trial, what is called CANPAP trial, which studied the role of CPAP in patients with congestive heart failure. What they found, there was no significant role of CPAP. They did not find improved mortality in these patients with CPAP. But when a subgroup analysis was done, and when it was found that in those patients who responded to CPAP, that means if a subgroup of congestive heart failure patient who responded to CPAP, and where there was an improvement in the central sleep apnea and ejection fraction, in such cases there was improvement in the mortality. So when you want to give CPAP to your patient of congestive heart failure with central sleep apnea, to give a trial of CPAP. If central sleep apnea improves, continue with CPAP. If that doesn't happen, then you can stop CPAP, because it may be counterproductive. In fact, on the long run, it may increase mortality in this patient. In such patient, you may give oxygen, because oxygen is another modality which can decrease loop gain. Now we talk about the next mode, which is called adaptive servoventilation. Now this is a modified type of bi-level device, and this is specially designed to treat periodic breathing, Cheyne-Stokes breathing, particularly in patients with congestive heart failure. Now it is also used for other types of central sleep apnea, like narcotic-induced central sleep apnea, complex sleep apnea, and idiopathic central sleep apnea is also being used. But primarily it was developed for this thing. So it's a type of bi-level device, but the difference is that it changes the pressure support on breath by breath basis. Because in periodic breathing, there is a crescendo decrescendo breathing. We can see here. So in periodic breathing, there is a crescendo decrescendo type of breathing. So with the result, the pressure support, as you can see here, changes according to the periodicity. So if the patient is making more effort, the machine will give less effort, less pressure support. If patient is making less effort here, machine gives more effort, and with this the machine stabilizes the breathing. Another very important thing in the algorithm of software of this device, adaptive servoventilation, is that it decreases minute ventilation by 10%, and with that it causes relative hypoventilation and increases carbon dioxide level, so that it doesn't go below the apneic threshold. So this is how you give a adaptive servoventilation. You give an EPAP to treat obstructive sleep apnea. Then you have auto inspiratory support, which varies from breath to breath and stabilizes breathing. And then if there is a central apnea, you give auto backup rate. So this combination here you have is what is called adaptive servo ventilation for this thing. So these are the devices which have been developed for central sleep apnea. So for central sleep apnea, you use CPAP, particularly those patients with congestive heart failure, mild to moderate, who respond to CPAP. Then to treat central sleep apnea, you can use backup rate, and then finally adaptive servo ventilation. Now, it is very important that this device should not be used in patients of congestive heart failure with an ejection fraction less than 40%, because in one of the SERV-HF trial, it has been found that this device has been associated with increased mortality. So must check the ejection fraction. The ejection fraction has to be more than 40% before you give adaptive servo ventilation. The last type of sleep disorder breathing is the hypoventilation. And for hypoventilation, the type of bilevel device which you use are different from bilevel CPAP and also different from bilevel ST. These are called bilevel ventilatory support. So how they are different from the bilevel CPAP and this? Because they are used for abnormal lungs, because you are going to give it support for patients of COPD, obesity, hypoventilation, and neuromuscular disorder. In these situations, there is abnormal lung mechanics, so you need higher pressures. So these devices have pressure going up to 30 or 35 centimeters, and they are available in spontaneous ST and T mode. And there is another special mode, what is called volume assured mode. So I will just quickly go because I know I have only a few minutes left for this. So this is the basic setting for a bilevel device, where you have inspiratory pressure, which is called IPAP. You have expiratory pressure. You have the EPAP. And the difference between these two is called the pressure support. And this pressure support provides enhancement to the tidal volume and supports breathing. But what happens in patients with the lung diseases, in patients with chest wall diseases like obesity, hypoventilation, kyphoscoliosis? So in such patients, the lung mechanics are deranged and their respiratory rates are high, their minute ventilations are high, their pressure support requirements are high. So these patients have problem of what is called ventilator patient synchrony problem. So because the respiratory rate is high, so the patient respiratory drive is high. To match the patient respiratory drive with the ventilator becomes very difficult, and that leads to patient ventilator asynchrony and poor efficacy. So to address these, the advanced settings are added to these bilevel. So bilevel ventilatory supports have advanced settings. So what are these advanced settings? These are trigger sensitivity, the rise time, the inspiratory time, the cycle sensitivity. So all these, can be manipulated for different types of lung diseases like OHS, overlap syndrome, COPD, and neuromuscular disorders. And the tidal volume here is a function of two factors. One, the difference between the IPAP and EPAP, which is the pressure support, and the other factor is the inspiratory time. Suppose you cannot increase the pressure support and you want to enhance tidal volume, then you can increase the inspiratory time. So in such cases, the patient's breath has to be a controlled breath. So that's how you have to manipulate inspiratory time. You also have to manipulate rise time. So rise time is from EPAP to IPAP, the time taken. So this also has to vary because it has to be less in COPD patient, more in OHS and neuromuscular disorder patient. So these are the different these things. I will not go into too much of detail about these things. IE ratio is very important. The inspiratory expiratory ratio, normal inspiratory expiratory ratio is 1:2. In patient with restrictive disorder like neuromuscular disorders and OHS, keep the IE ratio 1:1 because you need more time for inspiration. You want to recruit the lung, so lungs take longer time to expand. But in COPD patient, because there is an expiratory airflow obstruction, you need more time for expiration. The IE ratio has to be kept as 1:3. So the breath has to be designed in this patient according to the type of the pathology which you are going to treat. And then, so this is how you calculate the inspiratory time, expiratory time, and IE ratio. There are charts for it. The rise time can be increased for neuromuscular disorder and OHS. It should be decreased for COPD patient. Why it should be decreased? Because you need less inspiratory time, rapid pressurization, and you want to give more expiratory time for COPD patients. Similarly, cycling. Cycling means changing from inspiration to expiration. So this is usually either time related or it is flow related, and this can also be manipulated according to the pathophysiology you are going to treat. So you could see that we can have different settings for trigger sensitivity, rise time, inspiratory time, and cycling for OHS, for overlap syndrome, for different. So different situations of hypoventilation require different settings, and this is basically done to improve synchronization between the patient and the machine, and that's how you optimize the synchrony by asking the patient for triggering. Does the ventilator give you a breath each time you want? That means the triggering is occurring properly or not. Then second, rise time. Do you feel you get the blast of air? That means the inspiratory time is short, so you can adjust it. And do you feel your breath is cut off early or late? So accordingly, you can adjust all these things. So you also see that the leakage is not high. It should be only intentional leakage, and there should not be non-intentional or unintentional leakage from the side of the mask or from the mouth, because the trigger can interfere with the triggering, rise time, cycling, and also for in efficacy of these patients for this thing. Now, last 2 minutes, the rationale for using volume assured modes. So why we should use volume assured modes? Because we know that like CPAP pressure varies in obstructive sleep apnea patient, in REM sleep, non-REM sleep, supine, and lateral position, you need different pressure. Similarly, during sleep, the pressure support requirement to achieve a given tidal volume may vary in REM sleep from non-REM sleep, vary from supine to lateral position, and also vary from over a period of time if the patient develop nasal blockade or if there is a rapid increase or decrease in body weight. So in such situation, you keep the tidal volume constant and then give a pressure support window, so that when there is a fall in tidal volume, the pressure support increases. When there is an increase in tidal volume, the pressure support decreases. So this is what is called volume assured, because you keep here the tidal volume or the minute ventilation constant and then give a window of pressure support. And there are different, so you can see here, so you can give a pressure support window, the minimum pressure support and the maximum pressure support, and you fix the tidal volume, and this is how this works. So different manufacturers have different algorithms, because Philips uses tidal volume, Resmed uses alveolar ventilation. So accordingly, you can use all these things. I'll not go into the detail. And the last two slides, the devices are of two types. One, the devices which you use for obstructive sleep apnea, central sleep apnea, and when you use them for chronic respiratory failure, for intermittent ventilation, say nocturnal NIV. So if you have a patient of overlap syndrome, if you have a patient of obesity hypoventilation who has hypoventilation, you give them non-invasive ventilation only during sleep. So when you give partial ventilatory support, or when you give ventilatory support for few hours in 24 hours, you use what is called respiratory assist devices. So these devices are called respiratory assist devices. So what is the difference here? You don't use alarms here. So these are simpler machines, cheaper machines, and they don't have batteries, they don't have alarms, because even if you remove these devices, patient will not die. So patient is not in the life-threatening situation. Only thing is patient may little bit hypoventilate. So these devices are usually given by nasal mask, single mask with single tube, and you use vented mask. That means the fenestras are there on the mask itself. So these are called single limb vented mask, and that's and these are simple and cheaper devices. But once you use them for patients who are sick and where you have to give prolonged ventilation, 24-hour ventilation, like for patient of acute respiratory failure, patients of acute exacerbation of COPD, or neuromuscular disorder patients who require 24-hour ventilation. Now these are devices which require more sophistication. So these devices should have battery backups, they should have alarms, and they should be, usually you use double limbs, they should be non-vented masks, and they can also be used on tracheostomies. They are very expensive devices and they are called ventilators. So these are called non-invasive ventilators. Those are other one are called RATs. So these are just to give you an idea, because when you choose your device, you must decide accordingly that which device will work. So if you want to give continuous ventilation for acute respiratory failure, use ventilators. If you want to give intermittent ventilation, nocturnal NIV, then use RADs, respiratory assist devices, because of the difference in their cost, and also other features like battery backup, alarm systems, and those things. So, with all these things, thank you very much for your kind attention. And thank you once again, Dr. Nene, for this opportunity.
Thank you, sir, for a absolutely wonderful talk and for your professorial insights into a difficult topic. And you have made it so lucid and so simple that even I think the first year residents can understand now what different devices are, when to use them, and how to use them. We are profusely thankful to you, and more so because you have flight to catch tonight. And when you were packing your bags, that time you were preparing and presenting your slides. So really
Okay, thank you.
grateful,
It's
sir.
my pleasure.
Sir, sir.
Thank you.
So as sir has to take a flight tonight, so he would be logging off. And now we would be transitioning to the second part of the webinar this evening, which is the panel discussion. And we've got a wonderful faculty for the panel discussion. We've got a mix of senior professors as well as young dynamic pulmonologists from all over the country. And I would like to introduce Dr. Parvaiz Kaul sir, who is a professor of pulmonary medicine from Sher Kashmir Institute from Srinagar, from the northern part of the country where I was on duty 6 months ago. And it is always so lovely, hearing him and to get his kind of pearls of wisdom whenever you speak to him. And it's really very fortunate that we have him over for the webinar this evening. And he is known to everyone as he's been the editor in chief of Lung India, and he's the one who's changed the entire outlook of the journal over the last few years. And he's got number of publications to his credit. He's also the editor of Annals of International Pulmonology, and look at it, 1,29,000 citations. So not only he is very well published, he's well cited as well with the H index of more than 89. It's absolutely lovely to have you. Welcome, sir.
Thank you,
Also
Vikas.
have we also have my friend Dr. Arjun, who hails from Trivandrum, and he is the senior consultant and head of pulmonology at Kim's Health at Trivandrum, and he's a member of the Embark India registry. So he has represented us in not only sleep but also bronchiectasis, as well as the member of Isham ABPA, who gave out the latest guidelines last year for the management of ABPA, and he's also the member of specialty board for DNB respiratory medicine as well as for FNB sleep medicine, and examiner for DNB and MRCP. So all those who are aspiring to be, DNB, he might be your examiner. So, hear him properly and his
Yes.
answers. So you might ask them in exams. And he's also the member of Editorial Board of Lung India. He's also well published with more than 100 publications to his credit and very well cited as well. Thank you, Arjun, for sparing your time to be with us this evening.
Thanks. Thank you very much.
So next we have is Dr. Beauty Biswas, who's from Kolkata, and she is a consultant pulmonologist in CMRI Hospital at Calcutta, and she's got not only experience in sleep medicine, but also she's running a very successful severe asthma and allergy clinic in CMRI hospitals. She's got special interest in IP, ILD, as well as sleep medicine, and she's well published and researched as well. And she's got multiple awards to her credit, and she was All India topper in the exam in 2016 conducted by National Board of Examinations, New Delhi. And she's been awarded at various national conferences like NAPCON, EPICON, and also she's been a faculty in numerous conferences. So welcome, Beauty, and I'm sure all the residents and all our listeners will benefit with your wonderful insights into the topic.
Thank
We
you, sir.
also have we also have dynamic young pulmonologists in the form of Dr. Abha Mahashur, who hails from Mumbai, and she is presently consultant pulmonologist at Leelavati Hospital and Research Center, and the secretary of the Mumbai Scientific, Mumbai Chess Group. And she's also very well published, and she's had numerous presentations to her credit at national and international conferences. And she's also, been felicitated twice with the COVID Yodha Award by the Honorable Governor of Maharashtra in 2021. Thanks for joining, Abha. And we also have a young and dynamic pulmonologist who hails from Delhi, where I'm presently practicing, Dr. Aditya Chawla, and he's well known as the organizing secretary of Respicon India, which they have been doing for a number of years now. And I've always known him to be, active interventional pulmonologist, but I'm very glad to see that he's active in sleep medicine as well. And he's done his FICM from the Fellow of Critical Care Medicine, and he's got numerous fellowships to his credit, and is a member of various national and international societies. And as I was mentioning, that he's got special interest in interventional pulmonology, cryorecanalization, and cryobiopsies, where we have common interest, EBUS, and placement, as well as removal of stents, medical thoracoscopy, and glue management, which they have professed in the country over the last few years. Welcome, Aditya. It's great to have
Thank
you.
you. Thank you, sir.
So, without much ado, I'll go to the,
Hello, sir. So I would like to introduce Dr. Vikas Marwah. For sure, we cannot move ahead without we go through this milestone. A brilliant, eminent personality from our field, head of department professor, Department of Pulmonary Medicine at Army Hospital Research and Referral, Delhi. Has an interest in severe asthma, interventional pulmonology, NIV, and I'm sure in sleep medicine as well. We have a lot of awards on his name. Best Paper Award at NAPCON 2006. And then Military Award, Sena Medal, Presidential Award in 2022, President's Gold Medal, AFMC, Chief of Army Staff Commendation 2014, and Vice Chief Commendation 2011. Best Presentation at YTS Yorkshire, UK 2017. And very important research angle, where he was a site principal investigator with WHO Solidarity Trial, Solidarity Plus Trial WHO, ICMR's National COVID Vaccine Trial, with the development of Covaxine, and Indian National Pulmonary Fibrosis League. He's a member expert group of ISCCM, NIV, and IAB bronchoscopy guidelines. Thanks a lot, sir, and would be glad to have you on board for the moderator. Thank you.
Thank you, Abha, for the kind words. And now we go to the senior most panelists first. And I would like to ask Parvaiz sir a very important question. Though it has been explained very well by Dr. Suri, but I can see that there are a lot of pulmonologists who joined in late, and this important point needs further elucidation. So, sir, what do you think is the difference between a manual and an auto CPAP? Because most of the younger colleagues now tend to use only the auto CPAP. And which one do we prefer, and which conditions?
So, first of all, thank you, Vikas, for your kind words of introduction. And it really feels good to be amongst the young pulmonologists of the country who have the baton in their hands to carry forward the legacy that Professor Suri and the likes have left. And it really feels good to be a part of this program. So coming to the question, fixed CPAP versus an auto CPAP, with the trend going in favor of auto CPAPs now. So essentially what, after Dr. Suri so eloquently described all the various machines available, this is a very basic question. And the basic difference between the two is that one delivers a constant fixed pressure all night long, regardless of your needs, whereas auto CPAP automatically adjusts the pressure within a range that you have actually set on the basis of your real-time breathing patterns. So you can liken a CPAP, a fixed CPAP, to a steady, unwavering stream of water, whereas auto CPAP can be likened to a smart sprinkler system that turns up and down based on when it senses that the water is needed. And the cost is a difference because the auto CPAP is slightly more expensive, but often considered the standard of care now. It has an advantage of providing all the efficacy data plus detailed pressure graphs showing how your pressure needs have changed throughout the night. And there are never and never additionalities that have been added to the auto CPAPs, with their possibility of differentiating between a central and a obstructive sleep apnea, identifying Cheyne-Stokes breathing, identifying hypoventilation, identifying measures between upper and lower airway resistance. So what do we prefer? Generally, the young pulmonologists, I'm sure, and the trend is more in favor of auto CPAP because of its superior initial titration, enhanced comfort. Because as Dr. Suri said, that a part of a fixed pressure given throughout the inspiration and expiration may not be comfortable for many patients, and the adaptability to changes like weight gain, alcohol consumption, allergies, nasal congestion, sleep deprivation in different postures, supine, lateral postures. So essentially, that is not possible with a fixed CPAP. What is possible with a auto CPAP? However, fixed CPAP still has some and specific uses, like patients with certain comorbidities that Dr. Suri talked about, congestive heart failure, COPD, those with central sleep apneas, complex sleep apneas. A fixed CPAP might be actually useful. So essentially, if I want to summarize my answer, CPAP is like a manual transmission. It delivers one fixed setting, whereas APAP is like an automatic transmission. It seamlessly adjusts to the changes that are required based on the conditions. However, what is important to understand is that the ultimate goal is not to use a specific type of a machine, but to achieve effective and consistent therapy. And the best device is always the one the patient will use comfortably all night, every night.
Thanks, sir. And I think that was pretty elaborative, and most of the younger colleagues will benefit from that answer. So my next question is for Dr. Arjun, and this is regarding the use of humidifier in a CPAP. So should a humidifier be given to all the patients whenever you prescribe a CPAP, or how do we decide which patient is likely to benefit from humidifier?
Thank you, Vikas. A very important question, the use of humidifier. Now, humidifier, what by humidification, what we basically mean is to add moisture to the air that is being supplied by the CPAP. So the question is, should all patients need a humidifier? The answer is no. So there are certain indications where you need to give a humidifier. So basically, how do you go about it is basically what we usually do is a symptom-based approach. So you usually start the patient on CPAP. If the patient experiences some side effects like dryness of mouth or soreness of mouth or nasal congestion, then that means that the patient needs more humidified air to be given. In the cases, we can always add a humidifier. Most of the CPAPs have an option of adding a humidifier, where some come with a humidifier added already on. Certain other instances, for instance, if the patient comes from an area where there's dryness of air, it's a very dry climate or a very cold climate, again, humidification may be needed. Or for elderly patients, because of age-related changes in the mucosa, they may also benefit with the humidifier. But the question is, should all patients need? The answer is no. For instance, from the place where I come, Trivandrum, the ambient humidity itself is too high. So most patients don't need a humidifier at all. So we take on a case-to-case approach, case-based approach, and then decide whether humidification is needed or not.
Absolutely. It's a very lucid answer. And most people in our part of the country from Western India would need a humidifier because it's pretty dry, and especially Rajasthan, where there's a lot of dryness of mouth. So there are a lot of regional differences in the country. So my next question is for Dr. Biswas. So Dr. Biswas, there are various masks, which are required for PAP therapy, and Dr. Surya described about the nasal and the oronasal. Are there any other masks, and how do you choose a mask for a particular, device?
So first, I'd like to thank Amita ma'am and Rajadhar sir for inviting me and giving me this opportunity. Now, coming back to your question, there are various masks available, like nasal mask, which covers the nose from the bridge to the upper lip and secured with headgear. And it's best suitable for patients who breathe through nose. And in claustrophobic patient also, it is useful. Then nasal pillows are there with two small prongs that fit directly into the nostril, and it also suits for claustrophobic or anxious patient, and with whom the positive airway pressure requirement is around low to moderate levels. These are very light, and patient become more compliant in our daily practice, but may cause nasal dryness or irritation sometimes. There is also oronasal mask, which is also known as full face mask. That means it covers both nose and mouth properly, and it best for mouth breathers. And along with that, if the patient have nasal obstruction like deviated nasal septum or any nasal congestion, then this is for them. Along with that, if the patient have very high pressure requirement, positive airway pressure requirement, then it suits them, but maybe become claustrophobic for few patients. Then another mask, which is also known as hybrid mask, which combines the oral delivery with nasal pillow but does not cover the nasal bridge. And it best for patient with mouth breathing and nasal bridge irritation from traditional full face mask. It has advantages of good seal, less risk of pressure sore on the nasal bridge, but the limitation is it is not available everywhere and require special training.
So I think that's wonderful because lesser the plastic on face, better the adherence and tolerance. So the smaller marks is for claustrophobic patients and they are better tolerated. And we also have a full face mask nowadays, which is used especially in people who are bearded, so they cover the entire periphery of the face, and more for the sick gentlemen or people who are bearded nowadays, as we see a lot of them. And
Right.
also the helmet masks, which have also come during the COVID time. So thanks for the wonderful answer, Dr. Biswas. And my next question is for Dr. Abha. And this is regarding a topic which was briefly touched by Dr. Suri, which is the ramp time. What are the advantages of ramp time and how do you set it in various disease conditions?
Hi, sir. So, to begin with, I think I would again just repeat for the rest of the viewers that what is a ramp time. So, ramp time refers to the duration in which our machines they rise the pressures from the low comfortable pressures to the therapeutic level of pressures. So, it sort of gives you a little cushion during which the airway will not be subjected to a very huge blast of pressure. So, in the current era, adherence to CPAP is a big issue with us. So if this one particular thing can help the patients to have more comfort, it really makes it a lot of a difference for the patient. So it definitely helps by increasing the comfort and adherence to the machine, because in the initial part of the sleep where there is not too much of an airway collapsibility or the narrowing in the airway, we need lesser pressures. So if we set a pressure which is very high initially, patients may not find it comfortable, and that is what reduces adherence in most of the patients. So that is what is ramp time. So now usually we should prefer that in a new user or those patients who are very sensitive to the pressure changes, we should try to keep a longer ramp time. So it ranges between 5 to 45 minutes in most of the patients. And there are certain factors which we should consider. And the most important factor should be the individual patient comfort, which should be the priority. Second would be that mask choice, like how Dr. Beauty very nicely told us about the different kind of mask. So when you use something which has a limited interface apposition on the face, like a nasal pillow, and in such situations, we can go for like a longer ramp time so that it's comfortable for the patient in that point in time. Thirdly would be sleep latency. So if you have someone who falls asleep a little gradually or over a period of time, then have a longer ramp time for them, because that's what will suit them. So, by and large, as per the even recommendation of our Academy of Sleep Medicine, for new users or for those who have a pressure sensitivity, we should always start with a longer ramp time. And once the patient is comfortable, is set with the machine, then you can shorten the duration. We also have few machines who have an auto ramp facility where the machine itself senses that now the patient has gone into the phase of sleep and the pressure can be delivered according to that also.
So that's wonderful, Abha, very well described. My next question is for Dr. Aditya Chawla, and this is regarding leaks, which briefly Dr. Suri sir had alluded to. So are the leaks always bad? And when are the advantages, and how much leak is allowed in various kind of masks?
So, sir, the answer to your first question, we need to understand what is a leak, right? So, leak is any exit of the air from the system which the patient is using. Now, there are two types of leaks which we are having in the system. One is intentional and the other is unintentional. So, the intentional one, like Dr. Suri pointed, the fenestrations on the mask for CO2 washout that is given, that leak is intentional, which we provide so that the CO2 does not build up. And the unintentional leaks, they are the escape from the tubing or from the air or from the attachment where the tubing is ending in the mask or from the machine. So now how much is acceptable? It's acceptable from 24 to 30 liters per minute. That is the acceptable range of the leak according to the guidelines. But more than that is going to hamper the comfort of the patient. It is going to decrease the effectivity of the CPAP, the adherence also, and the threshold also of the patient. Now, the advantages of minimal leak are the target pressure. It maintains the target pressure. it enhances the adherence, and it provides comfort to the patient because that much blast, when it is filtered, it decreases and it makes it more comfortable for the patient. But now how to reduce this leak? Tighten the airway, tighten the mask, tighten the straps and everything. The whole system, which more and more when it is used for more and more time, it gets worn out. So we need to change all the attachments of the mask, and the right fit, like Dr. Beauty said, the right fit of mask is very essential to minimize the leaks.
So absolutely, I think that was very crisp. And it is a necessity and not an exception. So in
Right.
compared to invasive ventilation in NIV, it will always be there. You cannot completely eliminate air leak. So I mean, it's very heartening to see that around we've got 2,600 logins and we've almost 1 hour in the webinar and 2,600 people are still listening to all of you. So kudos to the team and the panelists. So my next question is for Koul sir, and this is regarding the inadvertent removal of CPAP mask at night. Many times the patient just rips off his mask at night. So what does this imply, and how can we set this right?
So I think because this is a very common and a frustrating issue for the patients, and addressing it is a very core part of a role of every sleep specialist. And when the patient unconsciously removes his CPAP mask, it's always not always a sign of failure. It's a sign that something about the therapy is not yet optimized for the patient. And what does it what causes it? Sometimes there may be a pressure discomfort. Pressure may be too high for the patient, because of which he feels suffocated or struggles, or pressure may not be right, which means that the patient has average pressure is right, but there may be still some events that could be happening, apneas, hypopneas, raras, that actually cause the machine to rapidly increase the pressure, and those surges can lead to your microarousals and leading to a removal of the mask. Sometimes the mask issues can be there, like there could be a poor fit which can cause increased pain on the pressure points, and that is too loose a mask can leak, blowing air into your eyes, and that can cause noise and dryness. There can be a wrong mask type. There may be discomfort because of the silicone on your skin, the headgear, or weight of the mask can be subconsciously irritating. Sometimes the patient gets aerophagia. That is when you swallow air because of the CPAP, which can lead to a feeling of bloating and then abdominal gas, discomfort. And this physical discomfort can actually lead you to remove the mask. Sometimes there is what we call as inadequate habituation, because your brain may not be still used to the fact that you're sleeping with a foreign object on your face. So during light sleep or microarousal, the primitive part of your brain might interprets this as a foreign threat or an obstruction and tells you to remove it. So, and then in rare cases, this behavior can also be pronounced in individuals who have disorders like parasomnias or sleepwalking or REM sleep behavior disorder. So, how to approach it is that we have to arrive at it step by step. Troubleshooting start with a simple mask adjustments, pressure features like ramp, progressing to advanced interventions if needed. And the tone should be reassuring, practical, and emphasizing that this is solvable through collaboration with the sleep team.
Absolutely. So there was very, practical insight. So, this removal maybe because of the pressure, the type of mask, how tight it is, even dryness at night, the patient, if he feels that he's dry and he wants some humidity. So all those are very practical points given by you, sir. And my next question is for Dr. Arjun, because, some of the newer machines which are available. So everybody knows about a BiPAP, but, how does an auto BiPAP differ from a BiPAP, and what are the various modes? If you can throw some light on it, Dr. Arjun.
Thanks, Vikas. We all are aware of the conventional BiPAP machine in which you fix an IPAP and fix an APAP. There are machines in which you can have actually varying in IPAP and EPAP, and which basically the machine uses some algorithm and automatically adjusts both IPAP and EPAP. This is what is called an auto bi-level device. So in a conventional BiPAP, we set the IPAP and the EPAP, and the difference between those two is the pressure support. But in an auto bi-level, we set three things. One is we set a minimum EPAP, a maximum IPAP, and a pressure support. So that depending on the patient's requirement, the pressure, IPAP and EPAP can vary. Now, the various modes that are available in an auto bi-level device, you have the CPAP mode or the automatic mode. Then you have the S mode, the time mode, and in advanced devices, you have what is called the volume measured pressure support device. Now, which are the conditions where this becomes useful? Number one is in patients who have OSA with severe, very high pressure requirements. Number two, patients in whom nocturnal hyperventilation is an issue. for all the overlap syndromes, so obesity, hyperventilation syndrome, neuromuscular disease, overlap of OHS with OSA, COPD or OSA overlap, and all these conditions, you usually use an auto bilevel device.
Great. So thank you, Arjun, for that lucid answer. So we have got another mode, and which is the AVAPs, and Dr. Suri sir had briefly touched upon that. So I would request Dr. Beauty Biswas to further, throw some light on the AVAPs mode, which is nowadays available in the higher machines.
So basically, sir, AVAP stands for Average Volume Assured Pressure Support. This is a hybrid non-invasive ventilation mode that blends features of pressure support like bilevel positive airway pressure with volume control. But instead of delivering fixed pressures, it adjusts the inspiratory pressures, that is IPAP, dynamically on a breath by breath basis within the set limits to achieve a target tided volume, which is typically set around 6 to 8 ml per kg body weight. And the ventilator basically uses a feedback loop to modulate the pressure support gradually to converge on the target volume. The older device used to fix the EPAP and only the IPAP varices, but the newer devices came with the variation of both EPAP and IPAP within the clinician set limit of minimum and maximum threshold. Now, the indications of using this mode. So it basically helpful in managing chronic hypoventilating syndromes where tidal volume consistency maintaining is very critical and respiratory mechanics or effort is fluctuating, like various types of neuromuscular disorders such as muscular dystrophy, amyotrophic lateral sclerosis, then restrictive lung diseases, obesity hypoventilation syndrome, COPD with hypercapnia, central sleep apnea, or complex sleep disorder breathing where CPAP or BPAP fails to maintain adequate ventilation. But the limitation is very complex in setup and require proper monitoring and titration.
For the youngsters is that they should not always go ahead, the whatever is new and latest is not always better. And there is no, comparison between these modes and the previous modes, which is the auto CPAP and the BiPAP modes, and AVAP is not better. So if you're not using AVAPs, you're not missing much. So you should understand the basic CPAP and BiPAP first, and then think about very complex conditions where the percentage is much less. So these are newer modes which you should know, but you should not always try and use it in your patients. So
Nice.
coming to the next question, Abha, is about the adaptive servo ventilation, which was briefly mentioned. So what do you think are the indications and where is it advised?
So adaptive servo ventilation typically came up for the chin stroke breathing, sir. So basically central sleep apnea, where our patient is either breathing very slow or has a very long pauses between the breaths. So adaptive servo ventilation has a, is there an echo which is,
That's it.
Yeah, there seems to be some echo.
is it better now? Hitesh, can anything be done?
Let me check my answer.
Is anybody logged in from two devices?
Yeah.
So probably, I think.
That generally happens.
Vishal, can you just check?
Can we just?
But it is for everybody, and there is some issue.
Vishal, are you there?
I think it's better now.
It's better now?
But-
Okay, yeah, it's fine.
It is better, but I think it's still there. Okay.
So adaptive servo ventilation, it basically gives us an opportunity where we have an altering pressure support.
One second.
So basically, we with every respiration, we have a target minute ventilation, and then the breath is delivered according to that with a backup rate and with an EPAP. Now, in the newer versions, we also have an option where an EPAP can also be upgraded up depending upon the snoring events, hypopnea, apnea events, so and flow limitation. So basically, it gives you much larger. It combines a flow limitation issue along with the ventilatory issue and an upper airways splint effect of the machine. It is indicated in central sleep apnea. So the pure indications are primary central sleep apnea, narcotic-induced central sleep apnea, treatment-related central sleep apneas, or complex sleep apneas. So these are the areas where we should be using adaptive servo ventilation. Now the only issue is though it came for a heart failure related central events where the ejection fraction has been more than 45%. We had a serve HF trial where unfortunately the device is supposed to give us a lesser minute ventilation, as Dr. Suri very nicely explained how and everything. But in a selected subgroup of patients, it was found that there were few events of hyperventilation, which led to respiratory alkalosis, electrolyte imbalance, and that's what led to arrhythmia and sudden death in these patients. So, as of now, the indications should be very carefully chosen for the patient where you're using it for a heart failure patient with a preserved ejection fraction, which is more than 45%, or in a treatment related central sleep apnea or a narcotic induced sleep apnea, central sleep apnea.
Absolutely, Abha. I think the word of caution regarding the severe heart failure patients where the mortality was higher, where you should not use, and you can go back to the CPAP in those patients where you cannot use adaptive servo ventilation. So my next question is for Dr. Aditya Chawla. So Dr. Chawla, do you think we should monitor these patients, or it is that you've given a CPAP machine to the patient and that is it? And if you need to call them back, what is the follow-up plan which should be there in place?
So, sir, we do need to monitor the patients. It is very essential because monitoring is going to ensure the efficacy of the machine. The AHI remains under control and the leaks are minimal. We need to assure that. Second, the adherence that patient is comfortable with the mask, the device that is placed, or the interface that the patient is using. And they are using it more than 4 hours per night because if the usage is less than 70%, it does not meet the international standards and we cannot match the data. The third thing is that the safety is very essential. If the patient is suffering from any events, central events during the CPAP and the patient is sleeping and nobody is there to detect it, so that can be a problem. And even the intolerance needs to be monitored by the patient. So we need to monitor the monitoring is very essential in the PAP therapy.
So the message for the young pulmonologist is that it's not fire and forget. So you have to get these patients back to your clinic and sort
Correct.
out the teething issues which have been there. They may be intolerance, they may be sores, they may be claustrophobia, and they may be humidity related issues. So you need to do that troubleshooting and you need to keep getting these patients back to see the compliance on therapy as well.
And whenever device optimization is needed, you need to switch up the pressure, you need to move the ramp down, the patient is not comfortable. So those kind of things need to be managed if the regular follow-up is maintained with the patient.
So very important points, Dr. Chawla, which is important, for these patients to improve the adherence to the therapy, basically. So my next, question is for Dr. Koul, sir, is that how should we monitor? So what should be the frequency, and can we monitor the patients who are on fixed machines? So auto, PAP, everybody knows that entire recording is there. You can get it on your apps nowadays. You can do a remote monitoring. So is there any method of, following up these patients who are on fixed devices?
Yes, I mean, because I mean, it's very important to know that there are pillars of PAP monitoring, as Aditya spoke about the objective data, and there is a subjective feedback from the patients and a clinical assessment that are also important. As he said, that you need to have at least 4 hours of usage every night, 70% of the nights in a 30-day period, because that is not only important from point of view of the patient's perspective, from the doctor's perspective, because he knows that whatever he is delivering is probably right, but also for people who are actually on insurance, because insurance requires proof of adherence, specifically in in the Western countries. And all modern, as you rightly said, BiPAP and auto CPAP devices have these available automated functions whereby you can download the usage data and take your decision based on that. Subjective feedback is also important as to how the patient's symptoms are there. If the patient is experiencing any side effects because of the usage of the device, then we must also get an idea about the therapeutic efficacy by looking at the AHI, looking at the leak data. Then what is you talked about whether we can use monitor, what do we use to monitor the non-auto devices. So there's a misconception that only PAP devices provide data. This is false. Modern fixed pressure CPAP and BiPAP devices are all smart and provide full efficacy data. The only difference is that pressure doesn't auto adjust. What we do is that patient brings their machine to the clinic, we remove the SD data card and download the detailed data into the proprietary software, which is like ResMeds. We have Rescan, or you have Philips and Koul, and then that will give you a detailed nightly report, which is your usage, your AHI, your leaks, your pressure graphs, pressure BiPAP graphs on BiPAPs, then event breakthrough. So yes, it is possible. It's a myth that it cannot be done on fixed machines. The key is to have a structured follow-up protocol that actually reviews the objective data in combination with the patient's subjective experience to ensure therapy is both effective as well as tolerated.
So that's a very important point, Dr. Koul, which you have brought out, is that a lot of young pulmonologists think that in the fixed device you don't get any monitoring data. So you do get these respiratory event index (REI), which you have to download, as compared to it's easier in the newer devices where there's an app which is there. But even with the fixed CPAP, you can get a lot of data. So to
Absolutely.
further elucidate, Dr. Arjun, what do you think are the components of this, monitoring? Most of the things have been covered by Dr. Koul, but any other components you think which are there in the follow-up of these patients?
I just reiterate what Professor Koul has said, because monitoring of the data is very, very important. We have seen how should it be done and when should it be done, and we also need to know why it is to be done. Basically, it is to ensure compliance with treatment, to improve adherence, to identify leaks if they are present, and then it also helps remote management. That is remote monitoring. That's what we do these days. We can sit here. The patient may be in any corner of the world. By Bluetooth, if the device can be connected, we can actually monitor and manipulate the pressures of the patient in the patient's home itself. The things that we basically look into is the adherence data, as has already been said, at least for 4 hours, 70% of the days in a 30-day period is what is by definition compliance with CPAP. You look into that. You look at the residual AHI, see whether the pressure needs to be increased or reduced. Look at the leak. We have already spoken about the optimal leak, which can be acceptable. And if it is more than that, you have to ensure that the mask tightening has to be done in a more perfect way. And then, of course, you look at the pressure data as well. What's the pressure requirement and things like that. So these are the components that you basically look into. And it's very important that patients should be periodically followed up and all these data checked.
Very crisp indeed, Arjun, and thank you for that. So, coming to the basics. So, Dr. Biswas, so are there any do's and don'ts which you tell your patients? Because when you're giving them a CPAP, what they should do and what they definitely should not do?
Yes, sir. Uh, we should advise a patient when they are coming to our OPD during the starting of the PAP therapy, first to ensure proper mask fit. It should be chosen based on their facial anatomy, their preferences, breathing style, and needs regular assessment. Then they should start slowly, build comfort gradually, try in awake state first, and then mask first, and followed by mask with tubing. This will help them to develop confidence, and we can advise them to use a RAM feature also to ease this. And if they complain about dry mouth, nasal condition, then we can advise them to use heated humidification, and we should advise them to adhere consistently along with the monitoring, that is at least more than 4 hours per night, ideally 6 hours, and at least more than 70% of the usage, that is more than 5 nights per week, to achieve maximum therapeutic benefit. And we need to tell them that follow up very essential and crucial to achieve the good results. Along with that, regarding the maintenance and replace of the equipment which is needed on a regular basis, like to clean the mask and tubing in a regular manner, as advised by the manufacturers. And along with that, we also should educate and support them regarding their disease, that is sleep apnea, the device, and regarding the troubleshooting features. And for that, we need to advise them initially to start follow up at 2 weeks, then 6 weeks, followed by gradually increasing the time over 3 months, 6 months, and annually. Some behavioral strategies also we should advise to adapt, like healthy lifestyle, sleep hygiene maintaining, weight loss, and counseling regarding the anxiety and claustrophobia, etc. And regarding the don'ts, we should tell them to avoid tolerating ill-fitting masks, because this can lead to leaks and discomfort. And don't ignore the hygiene, because it can lead to infection, and irregularity can lead to decreased efficacy. And of course, don't delay in addressing the side effects, we should tell them. and also we should support them mentally to adjust their fear and come out of claustrophobia, etc.
Absolutely. Very succinct indeed, Dr. Biswas. And to add to it, regarding alcohol as well and the other drugs which they are on, the sedatives, hypnotics which they are using, that's likely to worsen and they should cut down on their alcohol. And even if they're having, it should be at least 4 hours before they go to sleep. So all these things, the do's and don'ts are very important for these patients in addition to just, prescribing a machine. So adherence is always an issue with a chronic therapy, be it diabetes, hypertension, and there are a lot of dropouts. And especially when you're putting a obtrusive mask on a patient and who's not very symptomatic, adherence is going to remain a problem. So how do you address this issue, Dr. Abha?
Hi, sir. So, I think adherence related issues, I would say that a conversation at the outset changes a lot. This particular consultation, even if we are in our busiest of the OPDs, should be a long consultation because we need to tell them about what is correct. We also have to be ready for an anticipation towards someone else telling them how not to use CPAP. So, the moment this patient is going to step out, he's going to have probably a surgeon is going to offer them a surgery. He's probably going to have an uncle and aunt telling them how CPAP is not so important. So the first conversation is extremely important where we again reinforce that what is obstructive sleep apnea, what are the possible complications of the disease, why it is so important for you and me to use the PAP therapy. Already at this point, we should tell them that what am I anticipating? That you may feel claustrophobia. Be easy with yourself for a month's time. There is no ideal machine. It is each to one patient. So you try for three different types of machine, whichever fits you well, on which you are most comfortable, please buy that machine. So troubleshooting is something which is part of the phenomena. That after 1 month, come back to me with an SD card reading. We're going to sit down again. Objectively, what I see in the SD card reading and subjectively, what you feel is going to have a solution. But not using a machine should not be a solution. Now, when this patient comes back to us after the 1 month follow up, we probably should categorize the issues in a patient related issues and a machine related issue. So, in patient related issue, like Dr. Beauty also very nicely reinforced the fact that there is a lot of mental component or a psychological re-enhancement of the fact which helps in our patient. So, if your patient has claustrophobia, please do not go for a very bulky mask. Maybe use a smaller mask. It will help him to be compliant with the machine. If you feel that there is a lot of issue with the phobia with the mask itself, go for mask desensitization. Ask your patient to use the machine daytime when he's sitting idle, just to get a little hang of the machine, that there is no stress that in the night, most of them, they have a phobia that what if I have to communicate something and I'm tied to a machine. So they should know that they can nicely untie the machine without having any stress, so they can manage it on their own as well. That I have seen by and large improves their nighttime usage of the machine. Coming to the physical factors, if you feel that the patient has allergic rhinitis, please treat that right up front. You give them a nasal course of steroid if there is an allergic component. It's just the stuffiness. You can use the saline drops for the patient. Now, if you have a bridge which is very small, the philtrum, in that cases, please don't go for a nasal mask because patients will have problem to tolerate. Or if you have a mustache, this patient will not tolerate any kind of a apposition in this area. So go for a nasal pillow probably. Of course, if you have a pressure requirement which is lesser. Again and again, counseling really helps the patient for sure. Then after that, we have some machine-related corrections which you can do. Like Dr. Suri also in the beginning told us that the most important problem we face is a pressure-related issue. So if we facing something like that, then try to increase the ramp time for the patient. That will make sure that he doesn't get the blast of pressure together, will help with the compliance. Or secondly, you can do an expiratory pressure release. So when you have to breathe out at a lesser pressure or a pressure pause, that makes the patients very comfortable at some time. And then we again go back to our therapeutic levels after some time. Thirdly, if nothing is working, you reduce the pressure for the patient. So I think the most important part is that you yourself telling that it's not going to be very easy. Stick to me for some time with this. Educated people understand why, and then they are mentally ready. Okay, this is what the doctor has told me, and keep telling them there is a solution to every problem. Most of the time, it works very well.
Absolutely. Thanks for the wonderful insights, Abha. And my next question is for Dr. Chawla, because you see many times these patients, once you tell them that they've got OSA because they are overweight, they tend to lose a lot of weight and they lose 8, 10 kgs of weight. So what do you do with these patients? Do you repeat the sleep study or how do you go about managing these patients?
So first of all, sir, the follow-up is essential. As we are all talking, the comfort of the patient is very essential. So then when we do a sleep study, we call the patient 1 to 2 weeks, we check the adherence, we check the compliance of the patient with the tubing, with the mask, and mask is fitting. Then we call the patient around 3 to 6 months for a regular follow-up. And if the patient is now starting losing weight, like if the patient has lost more than 10 kgs, as you said, there is an indication of stopping the CPAP therapy or decreasing the pressure or decreasing the requirement. So we need to go for an immediate sleep study. Now, now the sleep study is recommended in some centers for stopping the CPAP therapy for more than 1 week and then going to do the sleep study. But it is not recommended in the guidelines. We can go straight for the sleep study. We can see the requirement of the patient for the pressure, and we can set that optimum pressure in the CPAP, and we can send the patient happy home.
Sure. Thanks. So now, some of you must have joined late, and we've got some basic questions about sleep lab and its infrastructure. So I would like to have the, senior sleep specialist, Dr. Parvaiz, sir, guide the juniors regarding what a sleep lab is and what does it do practically.
Okay, a very basic question. Sleep lab is generally termed as a sleep disorder center, and it is a medical facility which is equipped comprehensively, primarily to diagnose and sometimes even treat sleep disorders. Consists generally of private bedroom with an attached washroom, designed to be as comfortable as possible for the patient. It is hotel-like, connected to a central control room where the sleep techs sit. They monitor the patient throughout the night using sophisticated equipment. And generally, 3 beds are connected to a central station, and that is the most useful hookup that is used in the West. And the core activity that is performed in the sleep lab is an overnight sleep study, wherein we do a number of monitoring of, say, the EEG. We do electrocardiograms. The muscle activity is monitored. The heart rhythm is monitored. We have breathing efforts because of your belts around your chest and abdomen. They give you an idea about the effort of breathing. Then there are air sensors. You have oximeters to check the level of your oxygenation. Then a microphone that can actually look at your snoring. At times, we also do a titration therapy as a standalone managed treatment therapy in the sleep lab, or at times as a split night study where half of the night study is used for diagnosis and half for titration. In addition to this, we can also use other sophisticated investigations in the sleep lab, like MSLT, where we have to do a nap study to find out whether the patient has any narcolepsy or not. And sometimes in patients people who are normal also at times, maintenance of wakefulness test, which is the opposite of MSLT and measures your ability to stay awake in a quiet, soporific environment. And this is especially true for occupational safety certifications, like for commercial pilots or truck drivers. And that is pretty much what you do in a sleep lab. It is akin to a cardiac cath lab or a hotel lab for cardiology, and this is for sleep diagnostics.
Thank you. So that was, I think, pretty succinct for the youngsters and those who are uninitiated. So Arjun, would you like to tell that what are the key equipments required, to set up a sleep lab? Because a lot of these youngsters will be thinking of starting out early in the career.
Thanks, Vikas. Probably I'll talk about a level 1 sleep lab. I think there was a question also from the audience regarding level 1 levels of sleep study also. So level 1 is it's a complete polysomnography, which is usually done under supervision in a hospital. So in this, basically, you need a polysomnography machine. And as Parvaiz sir has said, you need all those things, like EEG, EMG, EOG, ECG, saturation leads, the chest and the abdomen movements, and the position sensor. And then, of course, the most important thing is to have a very, what you call a sleep-friendly room, a good comfortable bed and good comfortable pillows with minimum noise. So these are the things that are needed. We also have a video recording, which is usually done, that will help us pick up parasomnias, especially REM and non-REM parasomnias like sleepwalking and all those things. Then, of course, you need a control room where the technician sits and supervises the whole night sleep study. Ensure that there is a backup for the power, which is very important. If the power goes and then all the data goes, then you also need a CPAP as well as a BiPAP machine for the titration that is to be done. We also have something called a VPAP TX. It's a machine which combines all the modes. You can do a CPAP titration, BiPAP titration, or even an adaptive servo ventilation titration using the same device. So that is something which is good to have. Then, of course, you may need oxygen for, especially for type 2 failure patients who need titration. Apart from bilevel titration, sometimes may need to give them supplemental oxygen as well. Then you need a facility for the data storage and archiving, and then to retrieve it if needed. And of course, more importantly, ensure that the place where you do the sleep study, the patient safety is maintained and the patient's privacy is also taken care of.
That's wonderful. But I'd like to add that for the patient where the pretest probability is very high, you may not always go ahead with the level 1 sleep study, especially in a country with the cost is an issue, and especially the patient are not able to sleep well for the first night. So when you have a very in a patient who's middle age with very high pretest probability, so probably a level 3 sleep study, which is a respiratory variable sleep study, is good enough to prescribe the CPAP unless there are comorbidities to look at. So thank you, Arjun, for that. My next question is regarding training because this is an important issue because you need trained staff to run a sleep lab. So are there any courses, Abha, which you're aware which are which are available in the country?
So, sir, we have ASSM ka Step A course which is there. We have ICS ka course also which is there. So we have a lot of fellowship program these days. But again, with these fellowships also, my personal experience a lot matters if they have had an experience in working in one of the sleep laboratories in past, because these courses, not all of them are in-person courses. Like for example, we have a formal training program under ASSM, which is an A-step program, which is pretty good, which is like with American Academy of Sleep Medicine is a good course. But a lot of other fellowships are available these days, which are not in-person training. So they have a correspondence thing or a fellowship thing, and then 2 to 3 days of a course which is there. In India, the two good ones, which I've also asked few technicians around and have got the rating, is an ICS course which runs over here and ASSM course which runs over here. But I think even with our technical skills, we still have to tell them about the basics of all polysomnographic features in the lab. We also have to tell them about the sleep disorders, a basic idea, what they're expecting in the patient. And most important, I feel that they have to be trained about the other medical illnesses which can accompany. Like, for example, if you have a kid with Duchenne syndrome, or if you have someone who's got a heart failure, you also have to know about the first aid kits, and there can be a sudden crash downs. So, and then communication skills, of course, data processing. So, despite all these fellowship programs which they have, but in the end, the experience in working in sleep lab, it outweighs all these fellowship programs currently in the technical area.
So now all of know whom to contact whenever you want to learn, and probably Abha Sleep Lab is there to train you further and sort out all these queries. So you know the person to go to. So my next question is for Dr. Chawla, and this is regarding the cost of setting a sleep lab because it may be a costly affair for these patients to set up a sleep lab. And what are the challenges because you have got a good sleep lab in Delhi? So how did you set it up?
So, sir, the basic level of costing of level 3 sleep lab is around 8 to 10 lakhs. And when you set your standards high and you want to set up a level 1 sleep lab, it's the capital is going to cost you around 20 to 40 lakhs, depending upon what all comforts you are going to give the patient. So, like, jitna good डालोगे उतना मीठा होगा. So the comfort level increases with the cost. And now the challenges which are being faced for this maintenance is you need to maintain the standards according to the international sleep guidelines, and you need to have the trained staff. That is going to also add up to your cost. And regularly trained staff should be available. If they are not available, you may suffer losses.
So that's what I was trying to tell you, those don't get disheartened if you don't have that much of money. So start
Right.
Going for level 3, the apnea links.
Level 3.
So in case the pretest probability is high, and then you can take it from there, as you grow in the career. So, it's quite interesting that it's 10 past 10 and we still have 2,600 logins and there are some 160 questions. So I think you guys have been wonderful and there's such a lovely response from the audience and still so most of them are hooked onto it. So I'll take some questions which have not been discussed before. So this is regarding the first question is regarding the concept of leak, which is not clear to Sakat Bhomik. And can somebody elaborate and how to calculate the leak and how does it different according to pathophysiology? So Arjun, would you like to take that on?
Because I think this is something which have been discussed both in Suri's talk as well as in the discussion. So leak is something which is important, but we all know that it is inevitable as well. But you usually keep a limit of say 25 to 30 liters of leak is acceptable. If anything is more than that, then that means that it's the mass tightening has to be more done in a more proper way. So, and then you decide on the type of mask and nasal mask and oral mask, and the leak varies between these masks as well.
Sure, sure. So I think that was quite lucid. And the next question is regarding the CPAP prescription. So Abha, would you like to take that? How do you write a CPAP prescription when you diagnose a patient with OSA? What are the components of that prescription? I think it's a good question.
The moment we have a sleep study, first is we check for the efficiency of the sleep study. Then we go for the optimal pressure study once we have diagnosed a patient. So most of the time, the severity of OSA does not really dictate the prescription of sleep apnea machine. So we should go by the 95th percentile of the pressure, which tells me an optimum pressure for this patient. We keep a little window in the beginning, like I said initially. Please keep the minimum pressures to the lowest minimum possible. So I usually start with 6, and then you keep +4 from the optimum pressure as the higher limit. You start with a little higher ramp time for the patient. You write a prescription with clarity that this patient is going to require a long-term use of if you're using an auto CPAP machine, whatever mask. So auto CPAP, you have to define clearly minimum pressure and maximum pressure. Then you also write down the kind of mask you're going to offer to the patient and continuous overnight. After that, you have to say that we need to do a follow up after, say, 1 month of the patient coming back to you with an SD card reading. So, a prescription should very clearly define the kind of machine you're using, the kind of pressure you're using, the kind of mode you're using, the kind of mask you're going to prefer to the patient to use, and the duration minimum. So, like we said, that adherence is defined as more than 4 hours. Please try to convey this very clearly that 2 hours using the machine is not going to help. So a continuous use over more than 4 hours should be very clearly mentioned if you feel there is a gap between we communicating and patient understanding what I'm saying. So more than 4 hours is what patient is going to have a meaningful benefit back.
So I think that's very important. The duration here is very important for the patient. So there's a question regarding the quality check of machines. So Jay Kishan says that, how to differentiate between the branded and the generic PAP devices which are available from a medico-ethical point of view, because the cost difference is quite a lot. So I think it's a very practical question. So Dr. Arjun, would you like to take that on?
There are two aspects to this thing. The cost, of course, is a major concern, and the efficacy of the machine is equally important. So we can always go by the trusted brands that we are familiar and which we use regularly, because that will ensure that the patient certainly will get the benefit of using it. But of course, cost is also a major concern, because even a fixed CPAP machine will cost somewhere between 25 to 30,000 at least. And then there are machines which you get for at least 10,000 rupees, but some of them are even Chinese models which are available in the country. And there are some make in India models also coming up now these days. So if the patient cannot afford standard brand, then it is worthwhile trying this, but always keep in mind the possibility of this not being effective in case it doesn't work, and we may have to switch on to a more trusted brand.
I think that's a very practical answer, and you also have to look at the service aspects, because the bigger brands, they've got good service which is available, and especially when you're going to a smaller tier 2 tier 3 cities. So these Chinese brands and all may not give you any service if you're going to a tier 2 tier 3 city. So that is also very important when it comes to troubleshooting point of view. So there's a question about ideal indication of ASV and VAPS device in sleep disorder. So Dr. Biswas, would you like to take that on? ASV and VAPS devices in indications.
So basically, VAPs mostly helpful in chronic hyperventilating conditions like neuromuscular diseases, restrictive lung diseases, obesity, hyperventilation syndromes, COPD with hypercapnia, central sleep apnea, and complex sleep disorder breathing. And the adaptive servoventilation is more or less works in the same place, but it senses the peak flow. So these can be used, but we need to rational them, basically, the uses.
So they are definite indication for adaptive servo.
Very good, actually, yeah.
I would like to add to that predominantly wherever we have a central sleep apnea pattern for the youngsters to remember, I think the ASV is not a mode for a hypoventilating sleep-related obstructive events. It's more for a central sleep apnea event. And AVAPS is more for those areas where you're going to have a hypoventilating hypercapnic failure along with our obstructive events.
Yeah. So for the complex sleep disorders, I think AVAPS is required, especially patients who got OHS and they've got a drive related issue as well. And when it comes to central sleep apnea and when it is not severe heart failure, so probably ASV is something you need to look at. So the next question is regarding from Calcutta. So again, I'll give it to Dr. Beauty Biswas. So, in a level 1 study, APAP, is it not recommended, or you always do a fixed CPAP? in level 1 study?
In level 1 study, the APAP can be done, but usually the choice is CPAP.
Sure. So I think that is what, because we want to get the fixed pressure. So
Yes.
normally APAP is what is given to a patient for few nights at home, where you can't get him to the lab and the costs accrued thereof. So you give a APAP at home and then you'll come to know about the 95th percentile as we were discussing. So there's a question, is there any role of chin strap? So Dr. Biswas, you had spoken about this. What is the experience with chin strap, and especially if the patient is a mouth breather?
Chin strap can be useful for mouth breathers, especially if they are intolerant to full face mask. And if they wish to use the nasal pillow, then chin straps are useful. We have seen like these patients in our OPD and inpatients also.
Yeah, if there's a lot of mouth leak and the patient's got a nasal mask, we can just put on a chin strap to reduce the oral leaks which are there.
Yes.
So there's another question: how do cost and availability of PAP devices influence your prescription decisions in India? So Dr. Chawla, because this is a very North Indian kind of questions.
मतलब सर ये टारगेट किया गया क्वेश्चन.
Cost
Sir,
and availability.
the cost of the PAP devices is not according to the prescription, but it is going to be in compliance with the patient. We do provide a comfort level to the patient, and we do ask that, like, we inquire, we ask, then we land up to sometimes this type of a device that this is going to suit him also, and this is going to not burn a hole in his pocket. Like, we if the person is needing a normal CPAP, we don't prescribe him that 80,000 machine. We can do it with the 30,000 machine. And these type of decisions we need to make in our clinical practice in the Indian scenario every day, because it is part of the practice.
And I
Because
think
if you are going to leave it, they are going to go to another place, and then they are going to ask whether this, and you don't know what kind of an input you get. So it's better to tell the patient everything, lay all the cards on the table, and wait for the answer from the patient himself.
absolutely. I think it has to be tailored depending upon the diagnosis of the patient, severity of the disease, and also the affordability. So that is what we have to do in a clinic, have to have these discussions and conversations with the patient and prescribe what is best for him. So I think
Correct.
it was pretty interesting. And is there any role of helmet mask in a claustrophobic patient, Dr. Biswas? So helmet mask, we saw a lot of helmet masks certainly when we saw Italians use it during the COVID. And that is when we started getting a lot of experience of helmet post-COVID in our country.
But the helmet masks are not available sir everywhere. But the claustrophobic patients, some feel very nice to it, because this not closing their mouth, they are able to communicate, and this is not even closing their nasal orifice also. But it is not available everywhere, so this is a
Absolutely, yeah.
problem actually for them.
The beauty of these masks is that even in bearded individuals, people who've got mustache, sick gentlemen who don't want to shave off, so you can use a full face or a helmet mask in these patients. So the claustrophobia is much less with these patients. They can speak, swallow, and do everything. The only problem is the sound. So a lot of these masks, because it's a lot of pressure driven, so you have to put your ear muffs inside. So sound is a major issue, and more commonly it is used for type 1 respiratory failure, hypoxemic ARDS, where it has been used, like during COVID, we used a lot of helmet masks at that point in time, and it has been shown to reduce the mortality. So there's a definite mortality benefit in type 1 respiratory failure only with the helmet mask. So if you can get hold of it, it is good to have it, especially for the ARDS patients. So there's a lot of question on the devices and follow-up schedule, which I think we have already discussed regarding what are the benefits of using PAP therapy for sleep apnea, Arjun?
Lots of benefits, lots of proved benefits. Basically, starting from it improves the quality of life, it improves the sleep efficiency. People, the daytime sleepiness and tiredness goes off, so their neurocognitive impairment gets better. In patients with uncontrolled hypertension, the BP gets controlled. In uncontrolled diabetes, sugars get controlled. HbA1c level comes down. You name it, you have it. Atrial fibrillation prevents recurrence. Stroke prevents recurrence. So,
Also, I think they're very, critical professions where it is even more important, such as the
absolutely.
pilots. We had that,
Pilots,
where the pilot
truck
slept off.
drivers.
So mission critical, pilots are there, where it is there. And drivers as well, because he's not only going to kill himself, he's going to kill a lot of other people. If he's, a
Exactly.
lorry driver on the road. So that is
Exactly.
for, social benefit as well, that, these people comply with the therapy. Great. So, how can I ensure a proper fit and comfort with my PAP mask? So, mask questions are I'm all diverting to Dr. Biswas. So, how can you, ensure a proper fit and comfort?
Um, Mask is properly fitting, that can be known from the compliance report also. The leak part will be less than 24, as we already discussed, and there is less fluctuation of pressure if we are using APAP, and the patient compliance is very good. He feels better, and the overall after awakening from sleep, the quality of life is better because the sleep apnea which have corrected completely because of the good seal.
So I think it's a very important and practical question because the first experience of the patient to the mask is the most important. So if you get it wrong there, the patient is not going to use that machine thereafter. So whenever you're giving to the first time, I think there are sizing, apparatuses which is there, especially ResMed gives you the mask sizer which is there. So you can get the right size, small, medium, large. Most of the Indian patients will fit the medium. And the important thing is that when you're giving a fit, please do not tighten it too much. So I tell my patients and my technicians, especially, your mask is like a hovercraft. So it has to be left a little, loose. So over a period of time, it will get inflated and the mask rises. So that is the time it will take the shape and the contour of your face. So if you tighten it too much, it will lead to ulceration and there is going to be a lot of intolerance of the mask. So just keep one finger free on each side when you're giving a mask fit initially and keep it lightly on the face so that it lifts up when it gets pressurized. So I think it's a good question, good practical question when we are doing it at the bedside. And so mm, there's a question from Jaipur. What are the common challenges with PAP therapy and how can they be overcome? So Dr. Chawla, what are the common challenges in your setup with the PAP therapy?
So again, what I told you, the compliance, the adherence, the cost, these are all the challenges which we are facing when we are prescribing a CPAP to the patient. Patient is not able to use the machine for more than 3 hours, 2 hours, 4 hours, and slowly he starts to condition himself. He needs reassurance. He needs little points, nick and knacks, like you told, how to fit the mask and everything. And whenever the patient lands up in a comfortable level, then he is able to go on with the PAP therapy.
Absolutely.
Because before that, patient is having so many problems. Pressure is on the face, blast comes on the face. They are not able to use it for more than 1 or 2 hours. Patient is having discomfort, nasal congestion is there. The wife complains that the in the middle of the night they'll call me up. They'll say that the patient is not able to use the mask, and because of that he is not able to sleep also. So now you gave the mask for sleeping, and he's getting a disturbed sleep. Without that he was sleeping well.
Absolutely. So it
So
has to be
these
a
kind of
kind of a
things
happy
we need
marriage,
to fix.
You have to tell the patient, so it has to be a happy marriage. Slowly you'll get used to it
Correct,
over a period of
correct,
time.
correct,
And he
correct.
has to persist with it. So I think it's a very practical question. So there's a question regarding tracking the PAP usage and compliance. How can you do it and why is it important? This question is from Jammu and Kashmir. So I think Dr. Koul had to log out because he's got important commitment. So I'll direct this question to Arjun regarding the tracking of usage and compliance.
Very important. I think we discussed this in the panel as well. It's very important that you track the usage because it gives you so much of information. You will know whether the AHA has come back to normal, number one, whether the patient is compliant with the CPAP, whether he's using it at least for 4 hours for at least 70% of the days. That again is important to ensure that the patient is compliant, whether there are any mask leaks, what is the pressure that is required. All these can be known by tracking the data. And more importantly, recently, all the devices, we can actually remotely monitor them and we can actually remotely manipulate the settings also to ensure that the leaks are fixed, the pressures are, can be manipulated, increase, reduce as need be. So for all this, tracking the data becomes very, very important.
Absolutely. I think there is a question regarding, a lot of practical issues which we, face in the clinic day-to-day practice, which is regarding how do you handle the aerophagia? So what is your experience, Abha? How do you manage aerophagia and nasal congestion in these patients?
So, sir, we have to first ask if the patient has an existing nasal issue. Most of the time, they have allergic rhinitis, and when they feel stuffiness, that's when they start gasping the air from the mouth. So, if there's any nasal congestion, the priority is to take care of that. So, if you have allergic rhinitis, it's okay to give them antihistaminics along with a nasal local steroid for some time. Let that nasal congestion settle down, and then they start using. If it's a gap of a day or two, is fine, but they should be comfortable using. Only then they synchronize well. When they don't synchronize well, they start opening the mouth, and that becomes a habit and more aerophagia. If it's not settling, then for some time we can reduce the pressure. If it's a set machine, we can reduce the pressure for some time, let the patient be a little more comfortable, and then we go back to therapeutic level. But most of the time, taking care of the nasal congestion is the trick of the trade.
So to add to it, when you push in a lot of dry air, it causes irritation, and that irritation causes rhinorrhea. So I think dryness is a very important component which causes rhinorrhea. And a lot of my patients tell me that, for rhinorrhea, you're giving me a saline nasal spray. So it works because, it takes care of the dryness, and then, that drip, that rhinorrhea settles. So I think you should also look at prescribing the saline nasal sprays which are available in the market, because this dryness itself will cause some nasal congestion and discharge. That is something to look at, and many times we do prescribe prokinetics to these patients, because these patients have a lot of bloating, because all the air which goes in, it actually doesn't go into the lungs, so they gulp a lot of air subconsciously as well, which causes gastric distension and which can cause bloating in the stomach. So some kind of prokinetics, if these patients require long term use, and especially with heavy pressures also, can be very effective in our experience. So most of the questions, I think they have been answered. There are some brand specific questions which are difficult to answer. Resmed or Philips, which company is better? I think now it's only Resmed. Philips has been withdrawn because there were some cancer related issues. So there has been a recall from US. So I think, what is your experience? Are you still getting some Philips machines, Arjun?
Yeah. Now they have
Come back.
restarted bringing out the machines now. So in between, it's not available now.
So yeah,
Yeah.
so it takes time for them to come back to the government setup, but then probably, so for a period we were getting just Resmed because of the cancer related recall, and which I think they have fixed now. And from Gujarat, there is a question: how do you integrate follow up with comorbidities such as hypertension, diabetes, or COPD in OSA? I think it's a very good question because you have to look at the patient holistically. So, what do you do about the comorbidities in these OSA patients? So, this is for Abha. How do you look at?
So, most of the COPD patients, so first thing we try to understand that when we start using the machine, automatically we see that their blood pressure medication requirement starts to come down. So, after 1 month, we should always try to tell them that when you come to meet me for the follow up of your sleep apnea issues, you please do also meet your cardiologist if in case there is someone on board, because we see beautiful results in their blood pressure medication requirement. So they then start feeling a little weaker, or the blood pressure starts to get settled with lesser amount of medication. So that requires titration there as well. The similar things happen with diabetes after say 2 to 3 months. If they're using it for more than 4 hours a day, then that also starts to get better. Thirdly, with COPD, so mostly they start getting better with their requirement of additional medication. So if they are on regular nebulizations, we see that the airway swing starts to get better, and then their events of worsening start to reduce. So that way, clinically, they start stabilizing with the airway disorders as well.
Absolutely. So I think you need to measure the blood pressure, the sugars, and closely in contact with the primary care physician and look at these aspects as well, because you need to come down on those other medications, as they have a lot of cardiometabolic, comorbidities in these patients, and heart failure as well. Things start getting better with that. You might need to reduce. So I tell these patients, the CPAP acts like Lasix as well. So it reduces preload, it reduces afterload. So your diuretic requirement also comes down when patients are on CPAP and have got associated heart failure. So need to look at drugs as well. So there's a very good question from Dr. Babu regarding anxiety in a fresh patient. So how do you take care of anxiety, Dr. Arjun, when you have started this patient on a fixed pressure CPAP? Do you prescribe any anxiolysis or just you talk it out?
Since this question is from an army officer, I think you are the right person to answer that. But let me tell you two things. Number one is the more importance of patient education. Now, basically, before we put the patient on CPAP, we just show them a video of what the CPAP is and how does it work. And that actually takes a lot of pressure away from the patient. Second thing is, whenever we start a manual titration, we insist that the therapist should give a trial of CPAP to the patient without the pressure first, and then with at least 4 centimeter pressure, so that they get used to what the mass feels like and what the pressure feels like. Once these two things are tackled, I think then there is nothing much more need to be done for that.
So I think you should empathize with the patient first. all of you are, giving a CPAP should first keep the mask on your face. That is what I used to tell my residents and my technicians. When you are hooking up a patient with a mask, you must try and keep, when you're giving a high pressure, especially for NIV, 15, 20 pressure, you should know how it feels. Then only you'll be able to empathize. So it starts with verbal anxiolysis, and many patients who are very, very anxious, you may give a very low dose of, Alprax, alprazolam initially to get over that anxiety, because that doesn't, affect their respiratory drive. At low dose can be tried in some patients where anxiety still persists. So there's a very important question regarding, cleaning of mask. So what are the recommendations? How do you tell the patient to clean the mask and why? Dr. Biswas, do you want to take this practical question?
I used to advise them to clean the mask and tubing almost daily and let them dry fully. And humidifier water to be cleaned and replaced daily, and replace filters every 1 to 3 months. But regarding the changing of tubes and masks, ideally every 6 months, but it should be as per advice of the manufacturer only.
So I think, yeah, it is very important, and it is good to have a booklet for the follow-up for these patients in your clinic, which you can easily give to these patients when you are handing over a machine and a mask. A very simple thing which I tell my patients is that you can just take the face wipes, and when you get up in the morning, you have to clean the mask with the face wipe which is there. And it may not be practical to wash it every day, but cleaning with a face wipe is something which keeps it hygienic. Once a week, also, if they're able to do on a weekend, and they can use this wash up liquid, the wash up liquid which they use for washing their utensils, that can easily be used, any foaming agent, to clean the grease off. Why it is important? Because if you don't take the grease off, there is going to be more leak. So that hovercraft effect which I was talking about, so that will be lost. So it will not take the shape and contour of your face. There'll be more nasal bridge ulcers, there'll be more leaks, and there'll be a lot of intolerance. So mask cleaning is of, it's sacrosanct. It is of great importance to all these patients, and it should be explained, and better to give them a handout regarding that. So again, there are some questions about contraindications for CPAP. So are there any contraindications for CPAP? Abha, would you like to take that on?
So no absolute contraindication per se, but if in case we have a structural issue like a trauma patients where we cannot oppose the mask, in those cases, of course, yes. But then I think now we have so many variety, we have so many different kind of masks that I would not say that PAP therapy can be a contraindication. It would be an interface which can be a contraindication, but no absolute contraindication for PAP therapy.
Yeah, absolutely. I think if you have a burns patient where their facial burns, probably you can't put on the mask. But I think one indication is if the patient is at aspiration risk, the patient has got ongoing hematemesis or hemoptysis, there you don't want to put on a full face mask, because there a chance of he's at an aspiration risk. So probably somebody who's got an ongoing massive bleed, upper GI bleed, is you would not like to put on the mask. If you want, you can put a HFNC or a nasal mask, because the vomiters can come out. So these are the few things where practically you have to look at. So there's a question about now, Chinese products again. So physical hands-on workshop is what most of the people, I think Dr. Amita Nene will be able to take this on if she's around. So most of the delegates are looking forward to physical hands-on workshop. What strategies have we found effective in improving long-term compliance with PAP therapy? I think we've discussed it a number of times. And again, so a lot of brand specific. And what is the difference between CPAP, APAP, and BiPAP devices? This question is again from Kashmir. I think we've discussed it. So would you like to repeat, Dr. Abha, CPAP, APAP, BiPAP briefly?
CPAP is a fixed pressure which we give continuous to the airway. That is CPAP, continuous positive airway pressure. APAP is when you have an automatic setting where we can have a range of pressure, minimum and maximum, depending upon the airway narrowing and the pressure sensing. And bilevel PAP is when you give two different pressures, an inspiratory positive airway pressure and expiratory positive airway pressure, which is technically indicated in a ventilatory deficit issues than in purely obstructive event issues. So these are the three broad distinctions of the modality.
Absolutely. And I think we'll have just time for one last question now. We were beyond 10:30. And any experience with MAD, the mandibular advancement devices in India? So Arjun, have you had any experience with the MAD devices in India, and where do you use it?
Actually, our center, we have a very strong dental sleep medicine. So they use a lot of mandibular advancement devices. In fact, actually, in the last 6 months, I was just looking at the data today. We had 7 patients who were put on MAD. Basically, mild sleep apnea, low BMI, and patients who were not keen on using a CPAP, and they wanted an alternative to CPAP. But very interestingly, I just found out we are able to analyze the data, but I found out that in all these patients, the AHI have significantly come down as compared to the pre-treatment thing. I think we'll just write it up in publish.
So because a lot of our dental colleagues even give it to the severe, sleep apnea patients. So any word of caution? I mean, which subgroup would you like to try a MAD? Because that is important.
Mild OSA, low BMI, particularly in females. These are the things which we usually look at if the patient is not very keen on using a CPAP.
Absolutely, and they should not be having any dental issues because malocclusion, dental caries, because a lot of these devices they pull your mandible forwards. It causes a lot of salivation, and there may be some hygiene and aspiration related issues as well. So those contraindications also you need to look at when you're prescribing a MAT device. So I think it's been wonderful, and thanks to all our panelists. Still we've got around 2,500 logins even past 10:30 on a working day when we have to go to work tomorrow. So it speaks volumes about the kind of quality and which you have brought to the table and the kind of knowledge dissemination which has occurred with Indian Chess Society. So I think we would now like to call it a day, and I would like to thank all of you formally, and we can't thank you enough for keeping the discussions going, and it's been amazing. And thanks a lot for the entire dissemination. And I would also like to thank the organizing team, the Indian Chess Society, and also SIPLA, who are the academic partners for this workshop. And we look forward to seeing you all again during the hands-on workshop where we can take it forward from here. Thank you, ladies and gentlemen.
Thanks.
Thank you.
Thank you. Thank you, ma'am. Thank you, sir.